All right, everybody, welcome to Mentorship. So, very happy to have all of you here. Today, we have a very special guest, Dr. Sarah Turley. She is going to be telling us, well, I'll let you go ahead and say what you're going to be telling us. But one announcement first, we do have our spring meeting coming up. So, if you have not already, make sure to get everything in line if you're going to be joining us for our spring lecture series.
Okay. I'm going to try not to be a horrible millennial Gen Zer and figure out how to use my screen. Okay, cool. Awesome. Okay, am I cool to get started? How is it?
Ready to go.
Okay. Hi everyone. For those of you who I haven't met yet, I am Sarah Turley. I'm a PGY1 over at Henry Ford Hospital in Detroit. As you can see, I'm on work right now. I'm on OB night shift, so coming at you from shift. But I uh, previously served as Bradley's job as the director of student affairs, and I'm still active with the ACOEP organization. And I really like, medical education. I like doing these lectures. I like giving you guys resources. So I'm really excited that Bradley invited me to speak today on what I think is honestly a super important topic and something that if you can nail down early can really kind of make you shine when you're out on auditions. And also, our fourth years who may be listening in going into, residency, being able to give good, concise presentations is something that you're graded on and something that really can change workflow. So getting good at that is something that I hope you guys get out of this. If you've never done a presentation or it's something that gives you anxiety, I'm someone who really took the time to learn how to do it correctly. That was the advice that I got, and I'm hoping I can pass that on to you guys. So feel free as we go on, put questions in the chat. I'm happy to answer them. But I'm going to kind of work you through my process of presenting patients to my attendings and how tricks and tips I've picked up along the way as a medical student. Okay, so why is the presentation so important? When you're in an audition rotation or when you're presenting in residency, this is an opportunity for attendings to really grade your clinical knowledge. They do read your notes, but that's after, they put in their input. So this is their opportunity to see, how do you evaluate a patient and how can you kind of work through a workup? And sometimes it's really not about, how much you know or, if you exactly nail the diagnosis, but the way that you can come across speaking organized and laying out your clinical information can show clinical competency sometimes a lot more than, the exact right answer. So how you present this information is as equally important. In this presentation, it's not this story, it's not a long-winded kind of conversation just telling you everything that I found out. I'm giving you clinical pieces and clinical arguments against why I think this person should stay in the hospital, why I think this person is not suffering from a large heart attack and why they can go home. Maybe I don't know exactly what's causing their chest pain, but I'm giving you the argument that I think this patient is sick and needs a further workup, or I think we maybe are okay on this. So you'll learn in emergency medicine as you go on that dispo is king, disposition, where we put the patient is king. And sometimes with your presentations, that's a lot of the time too. Here at my facility, a lot of the times after I present a patient, my attending will look at me and go, okay, so with what you know right now, are they going to stay or are they going to go? And sometimes that is really the first step after you get past that kind of basic medical student sick versus not sick is okay, I know they're sick, but they're not super sick to where they need the ICU or an adult, but something's not 100% healthy. Okay, do I have to keep them or do they go? So that is kind of the way that we're going to work through this. When you're in the emergency department, this is kind of how the flow goes on auditions. You'll see a red on the board. A lot of the times, I suggest that kind of asking the resident how you want to go about picking up patients. Some residents, as you pick up a red, that also forces the resident to pick up that red too. So always check with your resident or whoever you're staffing with before you pick up patients. Med students make the mistake sometimes about wanting to, take initiative and pick up patients off the board, but sometimes it may mess up the resident and attending workflow. So always make sure to ask before you pick up reds on the board or ask how they want you to pick up reds on the board. If you have access to a computer, doing a quick chart review and we'll talk about the important things in that. I think I've had to work through as a resident spending time minimizing my chart review because there is so much information now that the way we have ways to connect medical charts, sometimes it can actually hinder you from what's in front of you and how the patient's presenting. Their note from a month ago maybe is a lot different from how they look now. So just be wary about how much time you're spending in front of the computer and how much time you're spending in front of the patient. Creating your presentation, I know people are like, oh, I don't like when students write down things. I always had a paper and I really made sure to lay it out because you won't have a computer in front of you. And remember, the way that you present this information is really a big part of the presentation. So if you have to have a paper in front of you, it's okay. I still use a paper as a resident. But you shouldn't be writing every single thing down in a giant list, okay? Then you'll present that to the attending or the resident, whoever that may be. And then if you present that patient, you are intended to follow their care. So that's kind of that part of taking ownership of your patients that people look for on auditions. So if I present that patient and I say, I think we should get an EKG, a chest X-ray, and a troponin, when those all come back and be like, hey, troponin looks good, EKG looks okay, I know we were kind of thinking pneumonia or acute coronary, but I think it's not the case given these results. Just wanted to update you. So that is how you show continuity and ownership of patient care. So that's the flow of everything, kind of what you'll do when you're doing these presentations. We're really going to be talking about this part of presenting. This is kind of what I use to structure my presentations. You'll see here there's Emra has a guide too as well, which I suggest, taking a picture of, and you can find it on their website too if you want like a pocketbook. It's very similar, but this is kind of how I like to present things. I start with a chief complaint. I moved into pertinent past medical, social, and surgical history. Old carts is really a big part of where this emergency medicine part comes into play. We're trying to say, okay, they're coming in with chest pain, but is this chest pain I should worry about? The ROS, making it very pertinent. A physical exam, which is honestly, I think, where a lot of students may slip up. And I'm going to show you some kind of tricks to help out with presenting that and making sure you're doing what you need to. And then setting a plan, that assessment and plan, which I think is the hardest part of everything. We're really good at history and physical taking, but bringing it together is the hard part. So I'm going to try to give you a little bit of, tips on how to bring things together for that assessment and plan. So this is kind of every single patient, every single chief complaint. I'm making sure that these are somehow involved in my presentation and in this order. This is the organization part. Okay, so this is there as well. Let's start with our first thing, chief complaint. I personally have found a little hack. I know sometimes they're like, okay, this is so and so. She's a 55-year-old female. She has a past medical, and they just go straight into the past medical history. I like to show my attending kind of what world we're working with. Miss Johnson can be coming in for chest pain. That's a lot different from toe pain when I'm presenting this medical history. So I like to start with something like, Miss Johnson is a 51-year-old female. She's coming in with chest pain. It started 2 days ago. And then I go into my past medical history because I want them to know why I'm telling them what I'm telling them. So if she has chest pain, I'm telling you about her CHF because she's coming in with chest pain and it's pertinent. So I think just giving a little bit of a blurb, you don't have to, I added the onset there. Sometimes it gives them a little bit more, but Mr. Smith, 19-year-old male, instead of going into past medical history, I just let them know he's coming in with abdominal pain and, some back pain that started today. Versus, Mr. Leo's coming in with his toe pain. It's been about a couple months, but this is the first time he's seen a doctor. That paints a picture for them off the bat about the large amount of information I'm going to spew at them. So I really like giving them a one-liner versus like name, age, gender, past medical history. I think giving them the reason they're here first helps to bring everything that you're about to follow with together. So example, Mr. Richards, 60-year-old male, he's coming in, especially the ones with multiple chief complaints. I like to lay it out. He's got about 3 chief complaints that I can really talk to him about. He's most concerned about his foot pain, but he's also coming in for chest pain and difficulty breathing as well. So that gives them a kind of layout to where I'm going with my assessment and plan. If you have those patients who come in and they really don't know why they're there, they told triage they had toe pain, they're telling you that they can't sleep and their whole body hurts since they made the medication and they've had chest pain for 9 days and every ROS is positive. I start out, Mr. Richards is 60. He's coming in with a lot of chief complaints, but what I could gather is he's mostly concerned about his chest pain, and also some body aches additionally. And then he has another complaint about some toe pain, but I think that's less acute. That gives them who this person is and why they're here. So all this information I'm going to follow with comes after. So I think adding in that is a little bit helpful and I've gotten some feedback on that they appreciate that. Um, so we know who we're talking about. Ms. Richards, she has chest pain. Okay. Pertinent past medical history. When you open up Epic or whatever you have, they're going to have a list. PCOS, fibromyalgia, diabetes, hypertension. They had an aneurysm back in 2019. They had a CVA back in 2025. You're going to have so much information, especially if you work in a place like we work where we have a really sick population. So figure out what matters. You just told me that she's coming in with chest pain. Does her shoulder arthroplasty 30 years ago matter? Probably not. But her heart failure matters and her COPD matters. She had a surgery, a couple months ago. That matters. I would bring it up. So make sure you're really selective. You don't have to take everything. And remember, as long as you know the patient a little bit, they'll ask you, do they have any, new meds or anything? They have gout, they started a new med. I don't have to give that to them off the bat because it doesn't have to do with what I'm telling them about. People will come in with multiple medical histories that seem really scary and really severe, but they may just have toe pain. And you don't have to share this whole medical history unless it's going to change the way you manage things. So that's kind of where I bring in these life diseases. So some things I always include in my past medical history, things that are going to change regardless of what they come in for, the way I manage it, the way I give medications, the way they're imaged, the way I give fluids. So those are big things like CHF. We give fluids to a lot of people. If they have CHF, I'm going to mention it because their fluid status and their cardiac status is really important in the way I treat them. CKD and ESRD, so many medications are cleared by our kidneys. ESRD patients are a whole nother bucket of patients. If they have kidney disease, I want to know because that's going to change my management, the medications I can give them for pain. I can give them fluids, things like that. Their electrolytes, diabetes, sugars are really important in the emergency department. DVTs and PEs, I think, are really big because you'll see a lot of those patients. And anybody who has them, always follow up with, are they on anticoagulation? Don't just see Eliquis on their chart and say DVT-PE on Eliquis. They maybe haven't dispensed it for a year. Okay, always ask compliance with anticoagulation. COPD, like I said, big things that are going to change: heart, aneurysms, brain bleeds or GI bleeds. Cancer and chemo status is also a big one because, cancer puts us at a lot of risk for another things like PE, DVT that come in all the time. Lupus and immuno disorders that would require steroids. Steroids change a lot of our body physiology, and then also seizures. And I will add to seizures and other things where they cannot miss meds. So like seizures, anticoagulation, those are big things where we really want to make sure that they're not missing medications. Surgical history, this is kind of self-explanatory. The big ones: abdominal surgeries, cardiac surgeries. If you want a nice one-liner for this, I always say, I'm like, any surgeries, you got all your organs still, gets a laugh 90% of the time. Pacemakers are always a great issue. I always say, any surgery on your heart, any like, devices in your heart. Anyone ever take an ultrasound or do like put some jelly, take a peek at your heart? These are easy ways to ask it. Alcohol and substances. Living situation is one that I did not realize is so important because it adds to that disposition. If this is an older gentleman who lives alone and is coming in for weakness, that's very different from the older gentleman who lives with mom, sister, brother, whoever else who's going home. So that's knowing their living situation. It's maybe will feel weird asking, but I'm great. Where are you coming from? Who do you live with? Just so you know, for disposition purposes, even with your young patients too, you'll get burned so many times on these patients who come in and they have legal guardians. And, that's going to change your workflow and your disposition. And then doctor's visits. When the last time you saw a doctor? Physical exam. This is your opportunity to shine. And I think it's such a freebie gimme that students don't take advantage of. When you're examining the patient and displaying that to the attending, take the time to learn the nomenclature. If I have a patient who's coming in with shortness of breath and I'm evaluating their legs, if I say, I took a look at her legs, they look a little swollen on both sides. That sounds a lot different from if I tell you, on my exam, I appreciated bilateral, like +1 to +2 pitting edema, but it was symmetric. I didn't see any overlining erythema, and I had pulses. That just told me so much more. No overlying erythema. I know they don't probably have infection. They had pulses. I'm not worried about ischemic limb. It's symmetric. I'm ruling out DVT. So you can even up your ante on your physical exam to help them show the clinical picture. If you can use the nomenclature, it sounds a lot better. I didn't hear any advantageous heart sounds. The rhythm appeared regular on my auscultation. When I auscultated the lung sounds, I didn't appreciate wheezing. Or you could say, like that's so much different than their lungs were clear. That tells me nothing. It doesn't tell me what you're hunting for. You're hunting for crackles that may show me that they have fluid or edema. You're hunting for lack of sounds or lack of air movement, maybe saying that they're not moving air as well or taking enough deep breaths, wheezing, things like that. Pulses are always a big one. Students always miss pulses. You guys all know, don't state anything you didn't do. That's a quick way to get messed up, especially when you say, their legs look good and they're in there with a pair of jeans and socks that are impossible to get off. I'm like, I know you didn't take those off. I'm a good person. I always take off their socks. That's like my standard. Even if they come in for anything, like I take off their socks, I check their pulses, I put on new socks. It's just in a habit of getting patients undressed. You will miss so much by not getting patients undressed. I've gotten burned already in intern year. It's so awkward, but you're doing a favor for the resident who comes in after because they're already in a gown and they've already been examined. Um, And just get in the habit of doing everything. When I listen to lungs, I listen to all parts of the lungs and I always do pulses. Lungs, I do the same way. Heart, I do the same way. Belly, I always do all of the quadrants. I always make sure that I check rebound. Get in a system of it because then you will miss less. Always three system involvement. And don't forget mental status too in your geriatric patients. There's so many times I see them like, oh, they have dementia, and he thinks he's literally like at the Coney Island station downtown, and he's in the ER. And you're like, oops, my bad. So do a good physical exam and learn the nomenclature. Read other people's notes and say how you're supposed to say it when you examine them. It will make you sound smarter and more clinically competent. Chart review. So you've seen the patient, you did your physical exam, you asked the right questions, you're seeing them now, you're coming back. Chart review, I always start with their previous visits because you can usually find a really good summary note, especially if they've been discharged. So I can kind of see a lot of the information that I maybe couldn't find on a first glance. Prior imaging studies are great because if you're maybe thinking, especially belly complaints, when did the last time they had a CT abdomen? Because, if you can say they had a CT abdomen about, 2 months ago, it looked okay. Their symptoms haven't really changed, a little, worse diarrhea, but since he had a nice scan 2 months ago, I don't feel like we need to scan them. Um, Prior diagnoses and past medical history, you'll miss patients don't really know a lot about their past medical history sometimes, and you'll miss the AAA, repair, the type A dissection that's known that they just didn't mention to you. Um, Research a little bit. So if I have a patient who's coming in with belly pain, it's okay to go on your phone and be like, I have a female with belly pain, like differentials. We have those things now. You're a learner. Give yourself a little bit of research because when you come back, they will question you. And if they say, what's that clinical calculator that you're thinking if she thinks you have a PE? You took a glance at it before. And so now you know what's in it and you look smarter. So be prepared, research your differential. Don't feel bad that you don't know it off the cuff. And then run it by the resident. Say, hey, I'm going to present this. A lot of the times they'll let you. But this is kind of when I go back and see the patient, I chart review. So when you're thinking about your orders, so we've seen the patient, I have my history, I got my pertinent information, I've done my good physical exam, I know how I'm going to tell that physical exam to my attending. Now what? And this is where a lot of students stop. You guys were all really good at, those first and second years of medical school doing an H&P and a physical exam, but what do we do next? So these are some common orders, and attendings will a lot of the time ask you, like, why? Like I always ask my students, like, them getting basic labs. Okay, what are your basic labs? What are you looking for in those? Like, what's the purpose of them? Right? Because I mean, all of these are a cost to our patients, and getting an IV access, nursing staff needs to do it. Make sure you know why. So here's just some quick hits. If you're going to order a CBC, something you could say, I want to order a CBC, things I can see on a CBC, I can look at their hemoglobin, see if they're bleeding or if they have anemia. I can look at their WBC count, see if they have a significant leukocytosis that may show me that they have infection. I can look at their platelets, see if they're thrombocytopenic or they have an infection, and because platelets are an acute phase reactant, maybe they're having some changes that may show inflammatory changes. So that's what I say when I have a CBC. A BMP, they love to ask you the difference between a BMP and CMP. BMP, the big things I'm looking for electrolyte abnormalities, sodium, magnesium, calcium being the big ones. Acid-base dysfunctions, you get a bicarb and an anion gap on your BMP. Kidney function is a big one. If they ask you, why you ordered a BMP, the easiest thing to say is, I want to know their kidney function in case I need to get some more intensive imaging with contrast down the line. Totally reasonable. It's great to know their kidney function, especially if you're going to order imaging. COVID and flu swabs are great to throw in. A UA, things you look for, dehydration, UTI, hematuria, in the sense of trauma. That's a great one to rule out if they're having like lower abdominal pain and you're looking for like urethral injury or something like that, just running a UA. Your CMP is everything in the BMP. I always think electrolytes, kidney function are the big things in the BMP. And then it adds on your LFTs and your liver function studies. So that's going to be AST, ALT. It's also going to have your bilirubin and your albumin and your alk phos. I always like to kind of add in like hepatobiliary involvement. So I'm like, I could get LFTs, look for hepatobiliary involvement or like any like LFT elevations. A VBG is great for your like COPDers or people who are working hard to breathe because it kind of tells us where they're sitting at in their respiratory and acid-base studies. Especially if they're requiring new oxygen, always a great thing to add on. Um, and then meds that you can order to start out with. Antiemetics are great. Pain medications are great. Always start small. Tylenol, ibuprofen. Again, we need to know about their kidney function to know if we can give these things. Toradol is a big one. They'll ask you, did you check their kidney function? Do they have CKD if you're going to give Toradol? And then fluids, again, if they don't have CHF, you're probably in the clear, but just having that history before you give them fluid boluses. If you're scared and you're able to put in orders, it's okay to start with 500 cc's. I mean, it's not probably going to do anything, but it's a safe, one to start with if you're new to ordering fluids. Things to always ask attendings about before ordering: CT imaging studies, D-dimers, and any like more intense opioid drugs. And then here's just a quick rundown of imaging studies because they'll always ask, what do you want to get? What imaging you want to get? CT abdomen pelvis without contrast for your renal stones. At my shop, it's called like a CT renal stone study. So some sites may have like a pre-order set that you'll use. Anything else really in the abdomen, you're going to do a CT abdomen pelvis with contrast. Right upper quadrant ultrasounds are great for hepatobiliary function. So if you have a patient with belly pain and their LFTs are a little bit bumped and you're a little concerned, you can always do a right upper quadrant ultrasound, look for stones, look for duct dilation, look for changes like hepatic steatosis or findings of NASH in the liver. Oops. And then if you are going to get a transvaginal ultrasound or a pelvic ultrasound looking for some type of gynecologic complaint or obstetrics complaint in a female, you better be doing a pelvic as well. My biggest pet peeve and one of the biggest pet peeves of my attendings at my shop is when someone comes up to me and says, I want to do a transvaginal ultrasound. Okay, you planning on doing a pelvic? Because that is a part of the physical exam, and it's something we need to do as clinicians, and it can really help guide your diagnosis as well. Um, CT dissections usually have some type of CT abdomen pelvis with contrast study. And then point of care ultrasound is also a great thing for you to incorporate into your imaging. If you want to kind of X Games mode this and be like a fancy gunner med student, one of the things for all my cardiac patients I did was I would wheel over the ultrasound. I would try to get just like a couple views of the heart, click record, bring the ultrasound back and be like, oh, and I threw a probe on their chest. Here's the views I was able to get. They're probably not good views. I don't know what I'm looking at, but I'm showing them this is what the heart looks like. And they can talk through your ultrasounds with you. So another option too, if you have free time, throw an ultrasound on them. See if you can see anything. See if you can see lung sliding or B lines. Okay, that was a lot of information. But here are my kind of big tips for giving presentations to attendings. Everybody is different. It is always safe and actually probably preferred to ask the attending or the residents, how do they usually like the presentations to go? Some of them want all the information. Some of them just want to know the quick and dirty, and they'll let you know and they'll stop you. So don't be, taken back by feedback. Start off with that punchline before you get into the past medical history. I think that sets the scene and why it's important. Talk slow. I cannot imagine being an attending with someone just spewing me information at a mile a minute. Take pauses. You don't have to throw everything out like you're dictating a note and just know it like, some of the senior residents do. Take your time. Like I think attendings appreciate when my presentation is more of a conversation and less of a me just spewing off information on a thing. Have a cadence to your voice. Slow down. If you feel yourself speeding up, you're going to say more ums, you're going to say more likes, you're going to get confused, they're going to get lost. I always pause at the end of each thing. So I start with my chief complaint. So and so's coming in, she's a 51-year-old female, she's coming in with chest pain. It's been for about the past couple of days. Some of her past medical history includes heart failure. She had an echo back in 2025 that showed an EF of 30%. She takes Eliquis for a previous PE and she's been compliant. So in regards to her chest pain, she said it started, 2 days ago. She was sitting on the couch when it started and it came on a sudden. She had some shortness of breath. So you see, it's a calm kind of story. Take your pauses, get them leaning in. Remember, you're making an argument here. You are a lawyer. You need to convince me that this patient doesn't need to go to the cath lab right now. Um, Talk like a doctor. And if anyone in here knows me, like I'm very off the cuff, very silly goose head. And I don't like the preppy doctor white coat kind of stereotype, but I think that this is an opportunity for you guys to really work on your public speaking and using the correct nomenclature. It will make you sound more intelligent, and we should be ones using this nomenclature. The doctor shouldn't say, the lungs sound a little cruddy. What's the crud? Is it wheezing? Because that's completely different than crackles. That means that's two different physiologic processes. So if you guys are unfamiliar with the words, just look it up, read a little bit, see the wording exactly what that is, and just try to bring it into your physical exam. I think it's such a easy way to win brownie points, especially on your MSK exams. Knowing a couple of the special tests, being able to palpate the landmarks. I don't appreciate any like suprapatellar effusion when I'm palpating. They have good range of motion with flexion and extension against gravity. Like you're not just saying they can move, like they have good range of motion. You can be so much more with this. Anticipate questions in pimping, take advantage of your downtime. If you have a patient with, belly pain, like kind of look up your differentials for belly pain in the lab values because you're going to be asked on them. Don't be afraid of the assessment and plan. I think the best approach to the assessment of plan, at least in the emergency department, is ruling out the nasty stuff. We kind of have it a little bit easier to where, our job is to rule out the bad stuff. And if you can at least tell me, why this person isn't having the seven main causes of chest pain that can kill them, I maybe we won't find out what's causing their chest pain, but you can at least work me through a good differential diagnosis of the bad things that we can't miss. And I think that's kind of the cusp of where you start in emergency medicine. Um, Ask questions to fit your differential. When you're seeing a patient and it's a female with shortness of breath and they're tachycardic, you already know you're going to have to be working up a PE. So make sure you ask those questions when you're in the room for your Wells criteria and your PERC rule. Have you ever had them before? Any OCP use? Any recent travel? Have you had a cough? Is there blood in the cough? Has your leg been swelling? Because that will build your differential when you go to tell the attending why you don't have to scan her or dimer her. And then always ask for feedback. Students at the end of the shift, it's hard. You can ask feedback for like clinical stuff, but always ask some feedback on your presentations. How do you think my presentations go today? Any feedback always goes a long way. Common pitfalls that students find themselves in is organization and jumping around. It's so hard to follow a clinical story when you tell me the HPI and then you tell me that they have calf swelling and then you tell me that the last couple days they weren't taking their Eliquis and then you tell me that their vitals were, not so good and then you're telling me about how 4 years ago they had a heart attack. I'm so lost here. So really structure yourself to stay in that organization. If anywhere you guys need to start, it's just getting down the organization first, then add in your differentials. But you have to get that basic organization down on every presentation you give. Take a stab at the assessment plan. Don't just stop and be like, yeah, I'm not really sure. And just kind of wait, like be like, I don't think this is ACS, but if just to rule it out, I probably would order a troponin and an EKG and a chest X-ray if I were thinking ACS. Like you can give a stab at it. It might not be the right plan for this patient, but it shows me that you're trying to make those steps from med student to resident and coming up with an assessment and plan. So I think that's where a lot of students kind of hold themselves back is, I don't think this patient's having a heart attack and he's going to feel stupid me working it up, but it's better than giving no effort at all. And you can always just say, I don't think this is what's going on because of this. But, if I was working him up for ACS, I would do a troponin, I'd do an X-ray. I'd maybe get a BNP if I'm worried about heart failure, things like that. Don't lie or hold back information. And these simple things. If you're seeing an abdominal pain and I ask, what was their exam like? When you're pressing on their belly, what was this like? It's okay. It wasn't super tender. Did you really examine that belly for an abdominal pain? I need to know, when I was pressing in the right upper quadrant, he was okay. Left lower quadrant was okay. Suprapubic seemed a little bit more tender, but he was globally tender throughout. But I didn't appreciate any specific point tenderness in the right lower quadrant. He didn't have any specific, like you can be so much more of it if you examine them. Like you did it. Just tell them that. And then not asking for feedback. That was the biggest way I grew on rotations was asking for feedback from my presentations. So let's talk through a couple of like big chief complaints and what you would put in those presentations. Chest pain, again, the onset, your old carts, everything is huge. Chest pain is really kind of like a broad umbrella, and you need to get in the tea of what's going on. It's a really big history type of presentation. The workup is pretty easy, but the history and kind of figuring out which bucket they fall into is the tough part. So really getting an onset. I always tell them like, literally talk me through your day to day. Like, what'd you do when you wake up? You said it started in the afternoon. Where were you at? Were you in the kitchen? Were you sitting in a chair? Were you driving? Were you eating? Like, ask the questions. Because if you just say, so tell me what was going on when you felt the pain. Patients are horrible at generalizations. Where were you at in your house? Were you on a couch? Were you watching TV? Is it associated with breathing? Like these big things, because I'm asking about PE, I'm asking about ACLS. If they've ever had it before is a huge one because you can really base your differential off of that. If it's getting worse, if it's getting better, if they've been seen for it before. Past medical history and medications are huge for chest pain. Blood thinners, if they're on anything like Lasix or Bumex, if they're on anything like a beta blocker, if they're on anything like a statin, it may show me a little bit about their cardiovascular risk. Past echoes and cath reports are such an easy way to get easy money points. When you sit down and you have a chest pain, go to that cardiovascular tab. When was their last echo? Because if you can show me an echo from a month ago and say, I'm not really worried about heart failure with this guy, and they had a great EF, and I don't hear fluid and their legs look good, I'm running with that. I'm probably not thinking it either. Maybe we don't have to charge them with an $1,000 BNP lab. Like that's saving our patients money. Cath reports too. It really lets me know their cardiovascular status. Your physical exam is huge for this one. Heart, lungs, and limbs. Okay. You have to check for edema. You have to tell me what their lungs sound like. You have to feel pulses. Okay. Think about throwing on a probe. Cardiac is such an easy one to just pull the probe to the bedside and record it, videos of it getting through your view so then they can kind of look at it too. And again, chest pain, we're ruling out the nasties. ACS, PE, tension pneumothorax, pneumonia, pericardial effusion, myocarditis, pericarditis. Have they been sick recently? All of the big main causes of chest pain. And then we can think about the other ones. I love throwing in GERD for a differential for my chest pain. I'm going to give them Pepcid, see if it helps. They may not be associated with eating, but it's really high in epigastric and it's worse when they lay down. So maybe it is. So I think chest pain is one of those give me money ones, but you have to get the history and you have to do a good physical exam in order to rule out those other things. So that's my kind of chest pain. If you can rule out the big killers, think of the other ones, musculoskeletal, costochondritis, GERD, acid reflux, PUD. Those are your other differentials. Abdominal pain. Guys, I used to hate abdominal pain from my presentations, but now I love it because one of my attendings told me the one time she was like, abdominal pain is the only thing where we really do have a grid. And yes, you do get referred pain, but the workup is about the same. If I have a patient coming in with epigastric abdominal pain, it's probably not an ovarian torsion, okay? Like, use your brains here. Just because a female is coming in with abdominal pain, you don't always have to rule out torsion. Do your physical exam. If they're coming in with, right upper quadrant pain, what's in my right upper quadrant that I have to worry about? I'm gonna run LFTs. I'm gonna look at their gallbladder. I'm gonna talk about eating. If it's the lower abdominal pain in a female, there's a lot of things there, ovaries, uterus, bladder, their colon, they have diverticulitis, things like that. So really tailor your workup to the location. It's always good to know symptoms, nausea, vomiting, the whole out, both sides, you need to know what's going on. Always, always, always ask last bowel movements. Constipation presents in such weird ways, and it can really come in looking like an acute abdomen. But once they get some pain meds, you'll find out they're full of shit. And I mean that actually, they are full of shit. Always ask your last bowel movements and their habits too. If they've been worsening constipation, if they're just having liquid, maybe they have a big stool ball down there. Um, for females and males, you're going to have your differential diagnoses. Prostatitis for males is something you have to worry about with pain with defecation. Also, the different STIs that we give for both males and females. Females always ask about pregnancy status and the GU questions, vaginal bleeding, discharge, dysuria, things like that. Surgeries are always big for abdominal pain because you guys know they put us at increased risk for bowel obstruction and other things. And you would hate to put cholelithiasis on your differential with someone who's had a cholecystectomy. Big way to look silly. Syncope. Also with the abdominal pain too, lift up their shirts and look at the skin on their belly because you will see surgical scars. You will see rashes. You will see bruising. I've had two people who come in with severe, severe right flank pain and there's vesicles on their skin. They have shingles. Don't get fooled. Lift them up. Get them naked. You chose emergency medicine. It's gonna be weird. Sorry about it. Syncope. This is such a great one to work up as a medical student. I want you guys to learn the syncope buckets, neurogenic, cardiogenic, our vasovagal syncopes. These are big, big, easy points because you can fit your differential in those buckets. You need those old carts though. You need to know prodromal symptoms. You need to know what they were doing before they led up to the episode because that places them in the buckets. And you have to ask the question, if they're a poor historian, I always take it back to first thing when you woke up, I want you to talk me through your day. If you help walk them through it, you'll be able to get the history that you need. If you just ask broadly, you won't get it and you'll be wasting your time. So syncope, I always ask, Did you feel some palpitations before? Did you feel short of breath before? Was it from sitting to standing? Were you standing for a long time? Were you eating or drinking today? Have you been sick recently? Any headache before? Vision changes? How long were you down? Did someone see you shaking? Did you pee your pants? Like, I'm asking these questions because I'm seeing what bucket they fit into, and you can present it as such. For syncope in this patient, I know differential diagnoses for syncope are kind of a couple main buckets. I don't believe this is cardiogenic syncope because she wasn't having any prodromal symptoms. She didn't have any palpitations and doesn't have any cardiac history. But I'm going to just make sure there's no arrhythmias with an EKG. I may add a troponin as well and a chest X-ray to make sure that I don't appreciate any cardiomegaly. That's like you're working through your workup because you've thought about the things that cause syncope. You guys know what causes syncope. You already know the assessment and plan. You just have to learn how to match up the history and what you want to do and see how they combine. So I love syncope. I think if you break it down in the buckets, it helps you guide your workup. And I think it helps you with a good assessment and a way to show your clinical knowledge. So if you haven't learned about the buckets of syncope and seen how people kind of work those up, look it up on YouTube so then you can present it in that way. I think syncope is a really cool one to give medical students because it's an easy one for you guys to work through. MVCs is one that I think the HMP is a little bit difficult because it's not something we're really taught, and there's a very big things we want to know in emergency medicine. So old carts, but a special old carts. It's more like broken carts. Were they restrained or unrestrained? Where was the car hit? How fast was the car going? And I mean, like, was it on the driver's side? Was it on the back side? Did airbags deploy? Did they hit their head? Did they lose consciousness? Did they have nausea and vomiting? The same things we ask for trauma. Were they able to self-extricate from the car and walk on their own? Or did someone have to get them out of the car? How's the other car? Their car may be fine, but maybe they have a nice, big old truck and they hit a Prius. That tells me a lot about things. And then how are the other passengers doing, both in the other car and the car that they were in? Your exam is going to be very trauma focused, a neuro exam, making sure you do your midline C-spine tenderness, range of motion, eyes, pupils, muscle strength. I have them squeeze and pull, kick and pull. Always make sure to look on their chest wall. I just pull down their gown and look on their skin, and I check their belly. When you present this patient, you're going to tell them all this information. I had a 65-year-old male who was the restrained passenger in an MVC that occurred tonight. They're endorsing headache, neck pain, and back pain. The car, they were the passenger, was driving about 35 miles per hour. They were hit from behind. Airbags did not deploy. They were wearing their seatbelt. They had no loss of consciousness. They did not hit their head, but they were endorsing a headache short after. They were able to get out of the vehicle and self-extricate, but paramedics did assist them onto the stretcher as they said they were feeling weak. The car survived minimal damage, but they don't really able to check up on how the other passengers were doing. My exam, I don't appreciate any tenderness, on the head or obvious hematomas or laceration. They don't have any midline C-spine tenderness, and you're just going to work through your exam. They don't have any chest wall tenderness, and I don't appreciate any bruising. Their abdomen is soft and untender without any rebound or guarding. I don't appreciate any, bruising on the abdomen. These are all kind of the ways you work through this because it tells them, do I have to CT their head? Do I have to get trauma involved? Am I going to have to make a whole workup out of nothing, or can they go home with Robaxin? A fall, same thing with syncope fall is you need to kind of get everything leading up to it because you need to decide is this a mechanical fall or is this syncope? Especially in your geriatric population, this is something that they will ask a lot. What type of fall? You have to ask. You have to ask for prodromals. Did they slip and fall going down the stairs, or did they get up out of bed, go to walk down the stairs, felt lightheaded, and then slipped and fell down the stairs? Different things. Injuries, distracting injuries, making sure you're doing your same trauma assessment. Ambulation, always make sure your patients can ambulate after a fall before they go home. And then this is again where that living situation comes into big play, especially for your geriatric patients. I had a patient the other night who came in with a fall, and I was getting ready to send him home. The daughter called me and she's like, "No, the reason we sent him there is because he wasn't able to get up after. Like, he can't take care of himself at home anymore, and that's why he had the fall. So, like, he needs rehab. We can't take him back home." Shoot, now I've been sitting here for 9 hours. I got to get case management involved. I got to get everyone else involved. This just completely changed my patient's dispo. So knowing where they're going after they leave here is something you guys should gather, and it helps us out a lot. Okay, takeaways. Always start with your one-liner. Give them something to snack on. Give them a little piece. Why are they here? Why are you telling me all this information? Give them a teaser. She's got chest pain. Oh, that's why you're telling me about her surgical history and her Lasix. Okay. Prepare beforehand, take a breath, really kind of look at your patient as who they are, and tell it as a clinical argument as to why they should stay or go. And tell the story slowly and in order. If you guys don't take anything else away from this, please just try to stay in order and stay organized. You can fill in everything else as you go, but if you don't have a systematic way to present patients and knowledge in a way that attendings can digest it, all you're doing is making more work for your colleagues. And then if you present on the patient, you follow the patient. That is how you are kind of graded on your ownership of a patient. Okay. So that's all that I have. I know that was a little bit quick, but the bigger things I wanted you guys to get out is, you're given all of this information, you're giving all of this, chart review, you have to see the patient. But if you can really lock down a history and a physical exam, you can do a lot with that, especially a physical exam. I just think it's so slept on and it really can lead your diagnosis and management and probably save you a lot of lab studies. I'm one who starting residency, I would just shotgun a million things, and my attendings have really kind of stressed on me. Why did you get that chest X-ray? Well, she came in with chest pain. Well, what did her lungs sound like? She febrile? She's 19. What are you looking for? And I'm like, you're right. You're right. Her lungs sounded great. She's not coughing. She's just having chest pain. I just wasted, radiation on that. So starting to look at it at this lens, but like making sure you stay in order, talk slowly, don't stress yourself out. You're not dictating. And take a stab at that assessment plan. At the end of the day, give a couple diagnoses that you maybe think are right. And maybe like end with some disposition. I'm not sure what's going on with them, but their vitals are not looking very good. They're tachycardic, they're febrile. I think they're actually, pretty sick. That tells me a lot more than you just telling me, I don't know if they're gonna really like our answer here for their chest pain. I would rather you say, I think they look sick enough that, whatever's going on, we might want to take a peek at. And vitals are a great way to kind of guide that conversation as well as your physical exam. Okay, so that is all that I have. I will put my email in the chat. I hope this was helpful. I hope it gave you just a little bit of some more specific examples of how to look at patients. But if you have any questions and, ask the residents on these audition rotations, ask the attendings for feedback, listen to other residents, specifically the interns and newer residents. When you're a second year to third year, the presentations get a little bit quicker and kind of just like, quick medicine. We're not supposed to do that as a medical student. We're supposed to have all the information, and they will tailor it back. But regardless, you have to present it in a systematic way, or regardless what you say and what you're right about, no one's going to be able to follow you. Okay, I will take questions if anyone has any. Um, but if not, I'll turn it over to Bradley if you have any, last minute things. But I'll put my email in the chat as well. Um, yeah, thank you guys for having me. I love coming to speak, and I hope that you guys